now. You see, Matt, Rob, all those years of training together and college and stuff like that. You got to get your social media game on, brother. Anyway, to me, as I up here we go. Let me see here. Let's see. It says Dr. Lookstein declined. Don't decline me, brother. In terms of the ordering of these tests, some of these companies now, I guess for liability issues, they're requesting that you have some sort of special licensure called a clear license. And it, oh, there he is. There's Dr. Lookstein. Oh my God. You look a lot different than we did in college, man. You're wearing the full gown and stuff. Could you hear me okay?
I can hear you. Can you hear me?
I could hear you great, man.
Okay, great.
First, let me tell you, heroes usually don't choose their role in life, but the dedication and the perseverance that it takes to continue that role is such a huge effort. I'm so proud of you as a friend. We went through our training together. I'm so psyched that it's you that's on the front lines. I've been speaking to you almost every day. I spoke to you during my illness. You've remained calm. You've remained cool. You've remained collected. And you, my friend, are the example of who the public wants out there. So with that amount of smoke blown up your ass already, I hope you're going to give me some information. Okay?
So thanks. But I could barely say anything positive about the work that I'm doing or the work that my wife is doing, who you obviously know very, very well. But the work that the nurses here, the emergency room staff here, the respiratory therapists, the anesthesiologists, the medicine house staff, they're the real heroes. So it's an incredible honor to be working with them day after day, just trying to make any difference that we can to hopefully save lives and keep people safe.
I think you've always been a very unique perspective to me in the hospital, because you're not only a clinician, but you're so involved in academic research, and you're obviously, as executive vice chair, very politically involved. So it's that perfect storm of having a lot of information that I'm hoping you could relay to people. Give us a little bit about what's going on, not just clinically, but politically and research-wise.
So I think that if people are paying attention to Governor Cuomo, he's a very good source of information. I can tell you that the numbers that he's showing every day are an accurate reflection of what we're seeing in New York City and the state. And so I think many of us who are working in the hospitals in the New York City area referred to last week as quote unquote peak week. We hit our largest number of volume for the emergency room, for inpatient admissions, and now plateau week, where it appears to be almost identical to last week. And I think many of us are shifting our efforts and our resources to try and figure out how we can maintain this level of intensity with regards to staffing, with regards to hospital resources for the foreseeable future. How long is Plateau going to last? We don't know. People are saying till the end of the month. People are saying till the end of May. I think we're now at the wait and see phase, but right now it is manageable. As dire as it seems, it's many centers in Brooklyn and Queens. I think that other centers across the city are reaching out to help them and try and decant their workload. And I think for at least the next several weeks, this appears to be manageable. So if there's even a small glimmer of hope on the horizon, I think that we all feel like we can manage this and we can do our best.
Now, I know a lot of, as a patient and as a physician and a lot of the people I'm speaking to, everyone's like, why isn't everyone getting hydroxychloroquine? Why isn't everyone getting transfused? Why aren't they giving these drugs to just everybody? You've told me, and you've made it very clear that logistically it doesn't work like that. A safe drug to someone who's healthy may not be safe for someone on a respirator. Could you talk about that?
Yeah, sure. So I'm sure that you saw the press release. I think it came out yesterday, that there was a trial in South America of chloroquine that was abruptly halted because the quote unquote high dose protocol led to cardiac complications. And as much as some people are embracing any kind of medical therapy to try and, again, just find some sense of hope in all this chaos, we have to perform well adjudicated, controlled research studies to show what's safe. And I think the best way I can put this into perspective is, right now there's something on the order of 550,000 patients in the US, 560,000 patients in the US. Thank God, only 22,000 have expired. And even though that's a devastating number, what it really translates to is that somewhere around 3.8% or 4% of patients that have tested positive have died. So conversely, 96% of patients are surviving. So what if we did a trial of chloroquine, just as an example, and we found that 90% of patients survived? Now, some people might say, oh my God, that's great. It's 90% effective. Only 10% of people die. But when you look at the national statistics, that's actually objectively harming more people than it's helping. So we really need to prove which populations this drug is beneficial for, if it's beneficial at all, first of all, and it really needs to be proven in a rigorous scientific way. So I know that everybody out there is desperate for any kind of medical therapy, whether it's chloroquine and antiviral medicine, but this really needs to be shown to demonstrate efficacy in the overall perspective that 96% of people that are testing positive are surviving and are doing fine. And you're a great example of that.
Yeah. Well, listen, I had hydroxychloroquine and I had a Z-Pak, and I didn't take it till day 12 because during my illness, I had tachycardia, fast heart rate, I had problems breathing. And although I was willing to take the Z-Pak, I was afraid because, again, we prescribe hydroxychloroquine in dermatology for lupus and other skin manifestations. But again, who knows when you're sick? I was afraid to take my Lipitor and Zetia for cholesterol.
Exactly.
Because you're taking all these things, you don't know what's going on, and it's just not so easy. So as a physician, I'm trying to self-treat myself. I wasn't even willing to take it. And when I did start taking it at day 12, I broke my fever a day later. Who knows? Was it my time to get better? Was it the hydroxychloroquine? I think what people don't realize too, there's not going to be one golden bullet. There's never going to be one drug that just cures everybody, not even a vaccine. And at best, we're going to have a group of drugs, a group of protocols, and they'll work for certain percentages of people at certain stages of diseases, correct?
I think you're absolutely right. And I think the most important thing that many clinicians, many researchers in academic medical centers around the country are focusing on is who is at greatest risk to have devastating complications, who's at greatest risk for organ failure, for death, and we just don't know yet. A lot of the risk factors are coming out in the series from Asia, from Europe, even some series out of the United States right now. Mount Sinai is just about to publish their first 1,000 patients of what the risk factors were for adverse events. And I'm happy to come back on and share everybody here. But we clearly know that medical comorbidities like hypertension, obesity, respiratory illness, diabetes, dialysis,
it's crazy.
These are major risk factors for adverse events, but we don't even know within that who is at greatest risk for fatal complications. And I think that's where most of the research is going to focus on for the foreseeable future, because we all want to save lives. We all want to identify somebody who comes into the emergency room and say, you have a far greater risk for developing organ failure and ultimately not surviving this. What medication can we give you the second you walk into the emergency room to change the trajectory of your illness, save your life, and make it that you can return safely to your family? And we just don't know yet.
Yeah, I think what's difficult for the public, because I've been watching the news on three fronts: as a layperson, as a patient, and as a physician. And I find it so frustrating. And again, being nonpartisan, I don't care if it's CNN, Fox, Wall Street Journal, The Times. they're regurgitating and perseverating. They take like one story out of Korea, the 51 patients. They take the one study about remdesivir, and they keep on regurgitating it, trying to put different spin on it for no other reason than to build their audience, because they're all in competition. And I find it so frustrating. I keep telling people, every study is a contribution to our knowledge base. But please, as a public, don't get too nervous and don't get too comfortable. You know what I'm saying?
Right. I mean, everyone's so enthusiastic about remdesivir and the
Uh, yeah.
the access for remdesivir is going to be expanded across the country and I think around the world. But you bring up a great point. The initial trial of remdesivir that was published in New England Journal just a few days ago showed 65% efficacy. And again, taken into the context of the United States, where 96% of people are surviving, maybe that number would have been higher if the patients didn't receive remdesivir. And I think it needs to be taken into the context. If you give it to the patients that we identify are at the greatest risk for organ complications, organ failure, and unfortunately death, and you give those patients that have a predetermined, extremely high risk profile, maybe we can save those patients' lives. And I think remdesivir should not be advocated for the general population. That's clearly not where it's going to benefit anybody.
Yeah. Being a research guy, how do you feel about your validity of your judgment of validity of a lot of these studies that are coming out of Asia? A lot of people are obviously concerned about, they're an information controlling government to begin with. And a lot of the resources we're dependent on are from information of the past from other countries like China. As someone who I'm sure reads papers and reviews things on a regular basis, do you have any wariness towards studies from Europe or China?
So I think that the most benefit that I've seen from the research out of Asia has been the epidemiologic work looking at who's at greatest risk for complications. And I certainly think that that's led to a lot of hypotheses here in the U.S. about who we can infer should be at greater risk, who we should keep in the hospital instead of sending home liberally, who needs more aggressive medical therapy, who needs more aggressive interventional therapy. In terms of the medical data, I think it's mostly to generate ideas. I do think the research has to be replicated in this country. I do think it needs to be very rigorous research, and I think we all just need to be cautiously optimistic that researchers in this country, likely in Europe as well, and in Asia, will be able to collaborate together to answer questions very, very rapidly. But I think that the single center, single arm series out of Asia don't answer clinical questions on how we should be taking care of these patients tomorrow.
Yeah. I'm going to let you go in a couple of minutes because I know you're busy out there. Politically, it really seems like, because I know you're very much into the coordination of care of the hospital structurally and logistically. Has the communication chain and politics of inter-hospitals, not just the Sinai healthcare system, but with other, have they lived up to your expectations? Are there any things that you would like to see improved that you're working on?
So I, for one, can tell you I think that Mount Sinai has done an unbelievable job during this crisis. And we have calls multiple times every day to identify what our state of preparedness is, with the goal of being sort of 2 weeks ahead of the curve. We need to be thinking about what are our challenges going to be 2 weeks from now, and make sure we have the resources, the staffing, and the infrastructure to support whatever challenges 2 weeks from now is going to offer us. We're on calls every day with our hospitals across the New York City area to make sure they have the resources. Right now, we're actually accepting more patients on the Upper East Side from across our health system, just to provide continuous support across the system than we are here just from our local community on the Upper East Side. And that's going to continue likely for the foreseeable future. I think we're all aware that unfortunately Brooklyn and Queens is getting the blunt of this at the local level. Mount Sinai is privileged enough to have 7 hospitals across the tri-state area. And so we are making sure that if any hospital is feeling a little bit more strained, we share that strain across the system. I can tell you from speaking to my peers across the city, whether it's NYP, Northwell, they have operationalized this in very, very similar ways. The city has really stepped up and has done an incredible job at facilitating our ability to take stress off any individual hospital and make sure that that stress is shared equally so that patients have access, they have adequate resources, and ultimately the greatest number of lives can be saved.
That's amazing. You know, it's funny. People have been asking me, people during political times and the stress of everything, people, of course, always have things to complain about and do, and they talk about comparing to other countries. I'm really very proud of our healthcare system. We could always complain. We could always look for improvement, but just the coordination of care that I see relative to what's going on around the world, I'm very proud of everything that we're doing. I know it's going to get better. We're collecting a lot of information. I think Janet Gray, our psychology professor and pre-med advisor, would be very proud of us. We've come a long way from dancing in the mug, you and me. And to think both of us actually thought we were going to become psychiatrists together.
Exactly.
When we were in training. So look at us
Right.
now. Please give my best to your wife, Dr. Danielle Bajakian, who's a vascular surgeon who's far smarter than both of us put together. She's on the front lines at Columbia Presbyterian. And listen, man, I'll speak to you every day. Keep doing what you're doing.
Absolutely. Be well, and thanks for everything.
Okay. See you later, buddy.
All right. Bye-bye.